Hi, everyone. Welcome. I'll just give it a minute or two as people join us. Thank you all for joining us. I am waiting for our guests to join us. I hope they will. In the meanwhile, I'm going to start. My name is Shabir Musa. I'm a family physician in the Department of Family Medicine. I'm glad to say that Manda Mudau from the NHLS is here. I hope that the DOH representative also joins us. Manda, thank you for joining us, and we'll get going shortly. Manda, if you could just mute yourself for now. I'm going to just share a little bit of information on progress within the district in terms of research, just to give people a sense of how things are going generally in the Johannesburg District Research Committee. This is an analysis we've done as of the 30th of March. And as you can see, we in fact have received well over 187 since January last year, 177 applications, which is quite large by standards of districts. But 87% of them are resolved. In terms of progress with these research pieces, research applications, you can see that we've been averaging at about 10 applications historically and through January to July of 2020. But from August, it's increased substantially since the new research committee has come into place. The applications have actually jumped to about 17 a month, and that's placed extra burden on the administration as well. And apart from this blip in December, January, where there were challenges in the administration, but I think that just the numbers dropped. You could see that this is on average, about 70% more than used to be. So in terms of what we monitor ourselves on is the turnaround times, and we're trying to get that sorted out much better. I think we've been working from very long timelines previously, as you can see, to keeping it within a month almost. And you can see that we're more or less keeping in that band, and we hope to make it better. It's less than a month that from the time you submit an application on the NHRD to the time that you get a response from us saying that it's approved, you will have it in less than a month. So that's what we're trying to work towards. There are obviously some applications you can see in pink where they are still being processed, and some historical ones that we need to resolve. So if you're one of them, I hope we can sort them out and avoid this kind of thing, except, at least a month going backwards and no more. So thank you for joining us. We planned this meeting, today's webinar, and it's been after a few months of not having these webinars. So apologies that we're just going to have a discussion, and we hope that it will include in the next webinar presentations of research as we used to have. So for today, we have asked for representatives of the Department of Health at a provincial level, as well as the NHLS, to share with us an important problem that we know researchers are struggling with. And in some ways, we get researchers who don't understand the way things work and often apply for or make applications to do research and then hit a brick wall when they get challenges, that we then say, listen, you can't ask for personalized information, as an example. So we'll come back to that. For now, we, in fact, have got a representative, as I say, Mr. Mudau from the NHLS. Mr. Mudau, perhaps you'd like to introduce yourself a bit more fulsomely, and then we can chat. It's really a chat about, you know, a few things that your colleagues have said you'd be able to answer very well. Mr. Bedard, perhaps you can show your video as well, so people can see who we are talking to and become more familiar with you. Thank you. Thank you, Mr.
Good afternoon, and thank you very much, Prof.
Great.
Musa, for giving me the opportunity. As you said, my name is Manda Mudau. I'm an epidemiologist in the Academic Affairs and Research Department of the NHLS. Basically, the Academic Affairs and Research Department, it's the research support office of the NHLS. We support all researchers and students across the platform with all matters related to research. We support funding, we support access to data and materials to use for research, basically. I've prepared a short presentation.
Yes,
actually,
I can allow you to do that. Let me just
yes, I'll project it just now.
All right.
Okay. Okay, I'm just waiting for you to stop sharing.
Oh, I'm not sharing. I think you should be. Oh, sorry, I am. Sorry. Thank you.
Okay. All right. So I'm going to do a quick presentation on the processes to follow when requesting access to biospecimens and data from the NHLS. So just for a quick background, the NHLS was established in terms of the NHLS Act of 2000 as a single entity to provide the public sector with diagnostic pathology services. And it serves 80% of the South African population. This is mainly the proportion of the population that is uninsured. One of the mandates of the NHLS is to support health research and surveillance, and also to train professionals in health, mainly pathology and public health. So just a bit of context in terms of why NHLS is such an attractive destination for researchers in terms of data and specimens. So our latest estimates show that we receive in excess of 100 million specimens annually. So that generates a massive amount of data and provides opportunities for big data analysis to inform public health. So just to go further, also in terms of how the resources are organized and what actually happens. So basically, there's 4 broad categories of resources that researchers can tap into. That's our facilities, our equipment, and staff. Biospecimens, surveillance databases that are mainly held at the NICD, and some research databases that are done by individual groups in the organization. So under biospecimens, usually you get 3 types of things. You will get raw specimens, and then you will also get biological materials derived from specimens during testing. Those are usually kept in NHLS laboratories for a limited time. And some of the specimens actually go to one of 2 biobanks that we have, one held at the NIOH and another one at Stellenbosch University. So with specimens also, you've got associated data. which you will find demographics, test results, and some limited clinical data. That goes into our laboratory information system and eventually lands in our corporate data warehouse. So just based on this, there are three types of requests that we receive from researchers usually. That's data, biospecimens, and requests for primary data collection. Under data, people request data for operations, patient management, surveillance, and the bulk of it is for research. And then in terms of biospecimens, people request leftover samples, and also diagnostic services for research, where a person requests testing for specimens that they collect during their research studies. And also under primary data collection, people will request to do surveys or to do testing and validation of some diagnostic equipment. This includes some industry players and manufacturers who request this from us. So in terms of sort of the demographic of our requesters, you have NHLS staff, usually students, scientists, pathologists, and people in management positions, and then external staff from research institutions, government departments, non-pathology academic departments, NGOs, clinical research organizations, and international researchers as well. And so recently, we had a policy for access to material and data approved by the board of the NHLS. That was published last year in August. Just a background on why that policy was drafted. The NHLS is obligated to provide resources for research. That's part of the NHLS mandate for the public good. So really, the policy was drafted in order to regulate access to NHLS resources in the conduct of research without creating barriers to researchers, and also to establish a monitoring and evaluation mechanism to inform the NHLS research strategy, and also to ensure legislative compliance. There are some laws that we need to comply with to ensure protection of patients and also adherence to ethical principles. So in terms of some of the ethical principles, these are really the basic ethics principles for any health research that you will normally find in the ICH GCP guidelines as well. Beneficents and non-malfeasance, there needs to be a balance between the risks we subject patients to and the benefits that we derive from the research, and respect for persons. Patients have the right to make informed decisions, and also justice. So just in terms of some of the statutory requirements, I won't even read through all of them, but we are bound by the National Health Act, the NHLS Act, Health Professions Act, Human Tissue Act, and also most importantly, the Protection of Personal Information Act, which recently came into effect. So just in terms of the process, so there are various departments that provide the services. So when people request data for operations or for patient management, that can be requested directly from the NHLS corporate data warehouse. There's a form that can be completed for that purpose and sent through to the warehouse, and then they go through their approval processes. And then for surveillance and research, that's specifically data that comes through the Academic Affairs and Research Office. We do due diligence in terms of looking at governance issues and seeing whether the research complies with all NHLS departments. And then after we do the due diligence, that then goes to the corporate data warehouse. Same applies to biospecimens that are needed for research. The only difference being that in terms of provision of the specimens, that would be provided by the laboratory where the specimens are kept, or the NHLS biobank. And then in terms of testing services for research, that can be requested directly from business managers, who then through their laboratory managers. And then the approval process. So applications can be done on the Academic Affairs and Research Management System. The URL is listed there. So one needs to create a profile on the system, and then they can do the submission process. There's different things that are required and some information that one is expected to complete. After completion of the application form, one gets an application number and an email notification. The application is then reviewed, and then an outcome is sent via email or a hard copy. So recently, we also included material and data transfer agreement. So before the material or data are released, an agreement is entered into between the researcher and the NHLS. Following all those processes, a call is logged for preparation of the data or the specimen with the relevant department or entity that provides whatever is requested, and then the requested material or data are released. So in terms of what we look at when we review the applications, we've got a whole checklist. And the things that we look at is whether the research complies with NHLS requirements. Does the project have ethics clearance? Is the request aligned with the contents of the approved protocol? Is the NHLS able to provide the requested resources? Is the research methodology sound? Are the requested resources appropriate for the research objective and methodology? How will the resources be used? And is the use of those resources acceptable? And how will the resources be stored? And is the storage process acceptable? So in terms of data, these are issues of data security mainly. And then we've got a committee. It's called the Biospecimens and Data Access Ethics Advisory Committee. So this was established to provide guidance to the Academic Affairs and Research Department in matters that would require further clarity or input. So this is normally requests that are complicated. So the committee would usually comment on whether the researchers are sufficiently skilled and experienced to perform the research, and is the research consistent with the broad aims of the NHLS and also the Department of Health, and whether there would be any public benefit derived from the research, and whether the requested material can be released without compromising patient management. But just to emphasize, this committee doesn't replace any other research ethics committee, doesn't grant any ethics clearance. So in terms of the contents of the material and data transfer agreement, or what researchers would need to agree to, they would need to use the resources only for the approved research. They also need to follow a protocol that is approved by an ethics committee that is registered with the NHREC. They need to maintain patient confidentiality, ensure that resources are stored securely, follow all applicable laws and regulations. Resources are not to be used for commercial purposes, and not to share the resources with third parties, and report any violations to the NHLS, and acknowledge the NHLS in any research outputs. And also we expect an annual progress report, and also copies of any publications that come out of the research. So a big issue right now, due to implementation of the POPI Act especially, is the release of personal identifiers. So, as everyone knows, there aren't really guidelines specifically geared towards research. So the NHLS has taken a rather cautious approach. So applications that require personal identifying information are reviewed by our BDAC, and that requirement is usually waived for surveillance and case-finding purposes. And then if data are granted, that's if it's reviewed by the BDAC and they agree that the identifiers can be released, the data are provided to the applicant in a manner that ensures that they cannot be readily linked to results or clinical data. And when an applicant supplies a list of patients to say, I've got these patients, maybe they recruited patients as part of the study, linkage would be done using whatever identifiers they provided, but the NHLS will release the data in a de-identified format and will provide a separate linkage log, which in many cases is a requirement from research ethics committees. I think that is it from my side. I'm happy to take any questions.
No, thank you very much. And I hope that the audience will use the opportunity to use the Q&A. There is a chat for any comments, but Q&A if you can. Mada, thank you. Those were very useful. That was a very useful presentation. It was really giving me lots of insight into how to approach the NHLS for any research. And as a primary care, a family physician in primary care, we really are wanting to look at some information in NHLS to understand things in the district. Just some quick requests. I think if you don't mind sending me a copy of the policy as well as the forms, we could just link it to the web page on this what you call this webinar, and at least make it available for us so that people could go back and look for it. One of the questions I have is your personal identifiers. What sort of personal, or how would you de-identify the data? So if, for example, a researcher wants to look at gender, race, information that might routinely be collected, area that it's come from, would those represent identifiable data? What would you regard as identification? ID and name?
Yeah, so that would include ID number, name, surname, usually the hospital file number, okay. And sometimes the specimen request number. So what we usually do in cases is that what is released, a pseudo identifier is assigned to patients. So you will get some sort of identifier, but you cannot readily link it to any patient at a clinic level. You can only do if you've got privileged access to the NHLS databases.
And it's pretty reasonable. I think most researchers don't need that kind of information unless they're doing some sort of follow-up. So here's a very useful question from Jaya George. Can we follow patients up longitudinally? I think you have actually suggested that by saying you're using a pseudo identifier. So could we look at longitudinal information?
So that, yeah, so within, yeah, so within the NHLS CDW itself, data for unique patients can be linked, and then you can have a longitudinal laboratory record for a patient. But when it comes to then maybe linking it to clinical information at a hospital, for instance, that then would require the BDAC, our Ethics Advisory Committee, that is the one that would make the determination as to whether that can be done. So we don't readily give approval for that. Okay. So it goes through an additional process. But yeah, if one wants to look at the data longitudinally, definitely that can be done. There's an algorithm that is applied in the data warehouse, which is able to identify individual patients and link their different results over time.
All right, wonderful. Well, that sounds like it's doable, and I think all that one requires is a good, clear rationale in your research project for doing it, and you obviously have committees that oversee that, but that it is pretty doable. I suppose that there's a little time involved in trying to get it past that kind of committee that you need to be aware of. So thank you. I think, Ms. Madhav, that was an excellent presentation. Thank you on behalf of all the researchers of Joburg. In Joburg and the district committee.
All right, thank you very much. So just before I stop,
yes, go ahead.
We are planning to hold sessions where we take researchers through the ARM system in terms of the whole application process, how you register, and all of that. There's one that we've scheduled for the 23rd of April. We'll share that invitation with everyone. It's going to be held. Yeah.
Send it to me. I'll put it on the web page that's linked to this meeting and with the recordings, etc. So I think please do that. There's a question about researchers from outside the country. Is there any particular problem or issue that you think they need to be aware of in terms of applications to you?
Not really, but in terms of specimens, for instance, if one wants to transfer specimens abroad, we obviously need an export permit for that. And then generally for external researchers, and this is an important point that I forgot to include in the presentation, for external researchers, meaning someone who's not in the employ of the NHLS, we require that they have an NHLS collaborator on the project. So this is someone who works in the NHLS, who would then become part of the project and give scientific input. So we attach people to pathologists for maximum benefit in the research, and we've seen that it works very, very, very well.
Okay. So just to clarify, that would mean that even I, as a researcher in primary care in a district, if I want to do some sort of research in the, on NHLS data from the district, I need to link myself up with a NHLS staff member. Is that what you're saying?
Indeed, yes.
I think then what would be very important is for us to get a good understanding of, the types of researchers or, their profiles in the NHLS, or is it something that if I were to say, fine, I'm applying to do, work on, let's say, pap smears in the district and the results, can I apply and then you allocate someone that you think suitable to the project, or would you want me to actually find someone? because there are challenges with that kind of finding someone.
Yeah, so our office actually assists with that. Most researchers actually opt that we identify someone for them. So we are in a better position to identify the most appropriate people because we know them, we know their profiles and the type of work that they've been doing.
Okay, great.
Yeah.
So your details will obviously be something important to provide us as to how they reach out, and it's obviously to you this arm. And I think we just need to get your details for people now to reach out to you. I think just in terms of research from outside the country, another issue which I think is very important to note is that the ethics approval needs to be a local ethics approval. You cannot come from outside the country with ethics there and expect to succeed in any of the work in South Africa. It has to be through an ethics of NHR's EC.
Yeah, we expect that the approval is with a committee that is registered with the NHREC.
That's right. So if you want to know more about all the committees on the NHREC, you can go to profmusa.com, the Joburg DRC, and there's a list there, or you can Google NHRD and it provides you a list in the policy documents there. I see we've got some more questions, so let's just see if we can get through them. Jackie Miot asks, how can we request access to data from NHLS if we want to confirm lab results on a specific patient medical record in a healthcare facility? So,
So that is usually reserved for people who are employed by the department. So if you're a nurse or a doctor employed by the Department of Health, and that's a patient you are treating, then a request can be made directly to the CDW to say, I need such and such data for this patient or group of patients. Yes,
and I think they provide you with the barcode, either the number on the barcode or the barcode itself.
Yes.
Right. I mean, or it could be, that you get in the facility that you are reviewing the records, get a local clinician to assist you by accessing that information themselves. They ought to be able to provide you their access through their password. So, Jackie, those are the two options you have. I suspect the local clinician would be the easier one, but you've got the option of reaching out to Mr. Modal. Jaya George asks another question. Are samples stored in the biorepository only on requests? So in other words, I'm assuming that how are samples stored generally? And how do you answer this question?
Yeah, so usually what happens in the testing labs, usually specimens would be stored for a specified period of time before being discarded. Obviously, there are some specimens that are kept for longer, usually your anatomical pathology specimens, the tumor biopsies, and all of that. In terms of, I'm not too sure whether I understand the second part of the question, but I'm going to attempt to answer it.
Yeah, go for it.
Case. So can one, just so that I know that it's the correct question that I'm answering. So the question is whether one can request from the NHLS for specific specimens to be stored on their behalf.
For longer than the usual.
I think certainly that would fall under, and we've had requests similar to that. So that would fall under a request for usage of facilities. So for instance, if you need free space for a number of specimens, so a request for that can be made to us to say, I want to use NHLS fridges to store 10 specimens for such and such a time. So we would review that type of application, and if the space is available and if that can be done, we then provide approval.
And how long is, you know, I mean, I suppose there are variations on specimens, but sort of serum, how long is it kept for, which I'm assuming is the average, most of the bulk of it?
Honestly, I wouldn't know.
Okay. Not a
Yeah,
problem. I think people who need this information can obviously request it to you.
yeah. We can
follow up.
find out on their behalf.
Right. Well, that sounds fine. I think Seshlule asked the question, are there any fees that are required to pay for this process to NHLS?
No, at this point, no, but it might be something that is introduced in the future. But just to clarify, that wouldn't be a fee for the data or for the specimens. It would be a fee for the service provided. So this would be compensation for the time that is spent preparing the specimens or the data, but we don't charge a fee for the specimens of the data themselves.
Right. Okay, no, that sounds great. And I think Nonhlanhla Menenge has asked the question, would you mind repeating the flow of application after obtaining ethics approval? Do you do it, you have to have ethics approval, or would you do it concurrently? You want ethics approval upfront?
So we prefer that people have ethics approval upfront, but it's not always practical. So one can actually do the applications at the same time. But yeah, but we usually prefer an application upfront, or if a person just has provisional approval. So most of the ethics committees know that NHLS has specific procedures. So what they would usually do when a person lodges an application, they would provide them with provisional approval, subject to approval from the NHLS.
All right. I think Nonhlanhla wants to get the flow of application. I think that Mandla, would you mind sending me the presentation as well? I think, and I can just put it up on the website as well. So it'll be there within a few hours. You can then go through that and see exactly. But I think the important thing is that it will go to the arm. You'll have the details, and then they go through a process. How long does it take generally to manage an application from begin to end?
So we usually give it a month, given that sometimes there's an exchange between ourselves and the applicant. So sometimes you might find that there's a missing document that we'll request, and then it goes through several reviewers, and we prefer to give them a bit of time in order for them to give the application attention. So about a month, that's what we give, although we are able to do it much earlier, in 2 weeks at times. Yeah.
Wonderful. Thank you very much, Manda. Really appreciate your time and expertise. I think this has been really great. Lots of people have found it very useful. There's one other question. I think, how do you ensure that research reports have been forwarded from researchers, especially outside South Africa? Or generally, how do you follow up your research? Researchers to say, where's your report?
Yeah,
something we're struggling with as well.
Yeah, so we usually just send out an email reminder or a short query to say, have you published anything? And then for researchers within the NHLS, we are usually able to mine that information. We actually go out and look for it, and then we ask the various departments to verify whether all the information is there, and then we link it to specific projects.
Well, we struggle with it, and we've actually said we're going to threaten them if they don't report to us with, blacklisting for the future. But I'm sure you're not quite doing that. But thank you, Manda. Really appreciate this. Great. Let's go to our next speaker. And I know we've gone a little long on time, but we haven't got any other presentations. So it'll be just Mr. Kumalo. Bekiseni, you can unmute yourself and go. Mr. Kumalo is actually part of he'll share a little bit more of details. He's actually been tasked by Cholofelo Adelekan, who's also part of the research directorate in the Gauteng Department of Health. But Mr. Kumalo will share a little bit more about himself. He's been sort of hijacked, I think, at the last minute to share, things about accessing databases. Mr. Kumalo, you can unmute yourself and show your video, and we can start with. And if you want to present, let me know if you've got slides.
Good morning, Prof, and good morning, colleagues. Also, good afternoon.
Yes,
it was a good day.
Yeah.
Yes. So my name is Mpekiseni Kumalo. I work for the Gauteng Provincial Department of Health in the Monitoring and Evaluation Unit. Ms. Adelekan is my direct supervisor. She's the chief director for policy, planning and research and health information monitoring and evaluation. I'm trying to present, but I can't. Oh yes, I can share now.
Yeah, I did allow you to share, so you should be able to do it. Go for it. Yeah, wonderful.
I should be able to share now.
Good. If you can, I'm not sure that you can, but you can show your video. I think people will enjoy it better. That's great. Yeah, if you just pull your screen slightly down, but that's good enough if you're okay. That's it. Wonderful. There we are. Good. I think we're seeing it. Thank you.
Oh yes, you can see my presentation. Thank you. Can you all see?
Yeah, if I can see, I'm sure they all can see. I think if you just put it on slide presentation where your arrow is, yeah, I think that'll be much better.
Okay.
Yeah, good.
Yes, so I'll just share with the colleagues some of the data access or data sharing procedures within the Gauteng Department of Health. And as part of cracking the ice or the introduction, it's that sharing of data for public consumption or for research is part of our priorities or of our Department of Health priorities here in Gauteng, which is in line with the governance principles that came from, or that were premised from the fact that department has been or has moved to the decision-making process that is driven by evidence, which data fortunately is evidence. So that once we have data-driven decision-making, we can ensure accountability issues as well as issues of transparency in the health system. But sharing of data, unfortunately, is governed by quite a lot of statutory requirements, which legislation, policies, and guidelines are there that have been put in place, and there's still a lot that still needs to be done. I'm sure we need to acknowledge that in terms of improving on the data access policies and guidelines. So these legislations or these pieces of policies and guidelines, they also apply apply to COVID-19 data. If you want to see or want to have access to, you want to get access to COVID-19 data. The first one, obviously, being the Constitution of the Republic of South Africa that was enacted in 1996, also being the supreme law of the Republic, and all laws need to abide by this Constitution. We have a second set, which is the POPI, which was also highlighted by the previous speaker. POPI, some of the sections just came in last year. We are still waiting for regulations. I'm not sure if they're out as yet, which are trying to practicalize the whole act. We have PAIA, which more guiding, giving access to information, and POPI is the one that regulates sharing information that has got personal identifiers. We have the National Health Act, which we are all in the Department of Health implementing. And in this National Health Act, there is a section that gives the accounting officers of different provinces and the accounting officers of the national department to say there must be policies enacted or guidelines put in place to make sure that the sharing of data is restricted and is done in terms of the law. We also have a few guidelines from the HPCSA, which are derived from the HPCSA Act. Our DHMIS policy, which is managing the data user agreement. So there are many more, but I just highlighted these few, just for this presentation. So this one was specifically, I made this presentation to the provincial advisor, to the Premier's Advisory Committee for COVID data, but the same principle applies if you want DHIS data or TB or HIV data. So these are the types of data, or these are the sets of data that we, the department, could share with the colleagues for research purposes or for other purposes that would need data. We have DATCOV data. DATCOV data is a line list which comes with, possibly if it's a line list, it comes with the details of patients, names, and everything. But for sharing for purposes of research or other public consumptions, DATCOV data or line list would come in a form of a de-identified data. So we'll remove all personal identifier, name, surname, some unique identifiers which has a possibility of linking that patient, address, postal address, as well as a residential address. All those kinds of information, when we share the DATCOV data, is removed. We've got a colleague there, Ms. Abrams, who is responsible for sharing the DATCOV data, as well as the DHIS data, which is aggregated data. The second set is on bed management reports. If maybe colleagues are supporting hospitals on COVID, and then they want to understand how is the utilization or presence of beds in hospitals admitting COVID patients, then we have got Mr. Silo who can assist on that types of data. Again, Mr. Silo also works together with the NICD. They do have, or they do provide us with the master COVID cases for Gauteng, which they put on one of the systems that we use here. And then Pet Silo is the one who managed that. We have got COVID Connect, and then Ms. Mogetle, together with some colleagues from DOH, they work together to get that data out. So these are just the colleagues who can help, and these are the kind of data that we can make available for sharing. So some of the information systems that we used in the department, we have DHIS, which is the reporting system, and it comes with the aggregated data for all the facility data. strategic health programs, efficiency, quality, all the data is there. On top of that, we also have the TIA.net, which manage. Oh, this screen is on the side. Where?
It seems fine.
It's fine. Okay.
Yes, it's okay.
Okay. Yes. So the TIA.net data, this is also a patient level data. TIA is basically an electronic register for HIV, ART data, as well as DSTB data. And for now, this data is now limited down to the facility level. So it's hospitals as well as clinics. Here, the provincial level or district level, we do have limited access to TIA, but it's basically down because this is just a register, basically, and registers are kept at the facility. EDR web, this one manages or is where DRTB data is captured for DRTB patients. And then again, there's an electronic web systems. This one we have it. Even here at the province, we do have access to, but it's also a line list of individual patients. So if colleagues wants to have access to this kind of data, unfortunately, we can't give them access, but we can extract the reports and de-identify it and share. I will share when I talk about the whole process flow. IGL web tool is mainly for quality assurance, but again, this is about patient safety, issues of complaints. It's not really much on strategic health programs, but it's just on efficiency and quality issues in the health system. DATCOV is basically collecting or is an electronic system, also a line list for COVID-19 data in Gauteng. So this is the process flow here. This process flow is process flow for data, colleagues. If you to issue data, it doesn't cover process flow for research, approval, and the rest. This process flow only kicks in once the ethics approval has been granted for that research institution. If it needs to go to the department ethics committee, come to that must also have been granted, as well as university HREC. It must have granted that particular research project ethics approval. If it needs to go to the district or the hospital, all those processes must have been completed and finalized. Then this process starts to kick in. So this part here is the part that just talks about general access, to stakeholders, including researchers, whoever is interested in getting the Gauteng Department of Health data. But this one was mainly for colleagues who are also advising the Premier, the Premier Advisory Committee, and all that. So I won't bore you much with this. I will start in this one. So once all the documents have been approved, ethics is there in place, it's not expired, then the project proposal was also approved, everything is in order. Then the participant or the researcher will send the request to us, health information via the email. Some they make calls. The minute they call, we send them the data request form. Because some of the databases, we can't give them access because it has got personal identifier. If we give them access, that will mean that we are now acting against the POPI Act. So in the request form, which I will show just in the next slide, complete the request form. If once it's well completed, all the details clearly defined there, what the researcher wants, then complete and send it back again. It's got details of who it must be sent to here at the department. Then it comes to us. Once it comes to us, it follows all the proper channels from the chief director signing goes up to the HOD for authorization or for approval. Once the HOD has approved that form, it comes to us again, and then we start to effect in terms of releasing that different types of data. If it's COVID data, to come to HIM to release that COVID data, and it will be a de-identified .gov. And then if it's again maybe TB or HIV or ART data, it comes again to us as HIM. If you want DHIS data, we also extract data from DHIS, and the colleagues who are responsible for sharing, they communicate with the researcher in terms of how the data will be shared. Then most importantly is that because in the form, the request form, remember this request form will also file, it is more like it's a contract between the data requester and the department. In the form, the requester would, the researcher would make it very clear that I will use this data for this purpose. If it's for research, I will use this data for this research project, and then there will be publication, or there will be a research report that will come out. Or there will be a presentation or whatever it is. Then once that research report is published, or that it comes out, or that the research paper article is published, then the researcher would also furnish us with that output of that particular research. It's very important. So this is just a quick data request form. Just few things that are important in this request form, because I'm sure after these colleagues will also be wanting to see this request form. The problem that we normally face, or that delay the whole process, is that first of all, most people who are completing this form, we find that data that is being requested, it's not clear. It just say HIV data. HIV data is just so big, it's so huge. We just have a lot of elements on HIV. I'm sure we have more than 50 elements on HIV data. So if maybe colleagues could be very clear and specific to say, what exactly do you need on HIV data? Do you need ART initiation? Do you need HIV testing? What exactly is needed, and then for what period? Because if you just say I need HIV data, I mean, if we respond, then we'll just give it for a last month. That's fine from our side, because it was not mentioned to say we need HIV testing data for the past 5 years, or for the past 3 quarters, or for the past 1 year, etc. So those are kinds of things that are very important. If it's very clear, it normally makes the process to be a little bit quicker. Then again, in the request form, because some colleagues will just say we need this data, then they don't say please remove patient identifiers. We don't need identifiers. I mean, all of us, we all know about POPI Act. Benefits of the information requested. So this one I won't go, but most important, what normally is just 2 and 3 that normally delay the whole process. But benefits to the departments, and how will the result be available? So all this, the colleagues can just maybe explain publication, they will send it to us, or it will help the department to improve on policies and planning, etc. So that's basically those 2 elements. Oh, and then the purpose as well. Purpose must be very clear. We receive forms that are just saying the purpose of this request is for research. Yes, we know it's for research, but what is this research all about? You see, things like that. Okay, so far, what has been made available is that, especially for COVID, okay, we do have DHIS data that has been shared with most colleagues who send the request. But for COVID, what we made available is that we have been making available case data from NICD. It comes through Impilo app. We have also been sharing that COV records, de-identified. But for the Office of the Premier, as well as Premier Advisory Committee members, we have been giving them the actual records. Bed management, we have also been sharing with the Premier Advisory team or committee. Also, we have been conducting GIS on the semi-anonymized data because the address was there just to create the coordinates of that particular client, so it's semi-anonymized. Then what was discussed again when this data was specifically for COVID was that, which I think would also apply to this platform, is that if there is a need for a researcher to get a semi-anonymized data, which will need a lot of motivation, that data cannot be shared with a third party in such that once the purpose of that data has been fulfilled, the data needs to be destroyed immediately. Or once that analysis is done, so it can't be stored if it's semi-anonymized. This was an agreement or an arrangement with the Premier Advisory Committee members, which, yeah, it was just a unique agreement. I'm not sure once we finalize data governance policies and data sharing policies, if it will also be applicable to researchers. Then just again to refresh memories of most colleagues that when we talk anonymized data, we talk data that does not have the name, surname, address, postal address, and some patient reference numbers. Sometimes in the health system or at the hospital level or clinic, we do have numbers like a file number. That file number, you can link a person, you can go and retrieve a file number and you get all my details. So some of those information, you try by all means to remove it if the data will be used maybe for purposes of research. So that's what is this long paragraph trying to say. I just summarized it in the interest of time. So what are we planning maybe going forward as the Department of Health in Gauteng is that first of all is to try and improve efficiencies in data sharing and make some of these processes even more quicker. And that one will be done through making sure that we finalize some of the data governance frameworks that are governing the sharing of data, as well as some of data-related policies. The minute we have these frameworks in place that are guiding the whole process, then we can even go and put some of the information on what we call is the GPG website or on our intranet, something like a frequently asked question. There will be a question and an answer, so that the researchers can get information without even calling us or writing emails, long emails to us, and things like that. On top of that, once we have the frameworks and related policies finalized, we are looking at getting maybe data access or data sharing delegation decentralized, so that if a researcher wants the data maybe for City of Johannesburg, you don't need to come to the province. The City of Johannesburg, because they will be delegated to provide, to share their data. We just say we have delegated power of sharing to you as COJ. Please share the data in good faith. So these are some of the ways forward that the department is proposing to put in place. And they were discussed in the health data workshop that we held somewhere last year, if I'm not mistaken, it was June or August. Some of these resolutions were taken as part of the next step. So we are also working on it from our side. I think I will end there, and I hope colleagues understood my presentation. Thank you very much.
No, thank you very much, Mr. Kumala. I think that was really very, very useful, I think, and clear enough. There's one question from George. Which database do I use for access to non-communicable disease information, such as blood pressure and diabetes? I can answer, but you can, if you want to volunteer first. Mr. Kumala, yeah.
Oh yes, so you can answer after me. So non-communicable disease, diabetes, we have them. Data is being collected, is on the system called the DHIS.
Yeah. Yeah, in fact, some of the questions I have are related to the fields of data collected. I just want to bring up my questions quickly. So I think that from if you want to know what is the kind of exact fields, any person doing research ought to be able to in DHIS to look at the tick sheet that is in front of any clinician. Essentially, that information is mostly the information collected that lands itself in the DHIS. And Mr. Kumalo, you can correct me if I'm wrong. I'm not too sure about what exact data comes from the Warbot team, whether that's all a separate data tool that lands up in the DHIS, because I've got the impression that their data also is getting into the DHIS. I think that tier.net, if tier.net and I think you mentioned the tier.net and the MDRTB, the DRTB, those things would be, again, based on the tools that are used. So tier.net would be the kind of HIV tool that is used where clinicians are expected to fill in information, and that lands itself into the tier.net. So if you're wanting to know what exact information is being collected, that's where you need to go to. Now, I'm not very sure whether you have an idea of what the ideal web tool is, but I suspect it is all the data collected in the ideal clinic manual. So in other words, those sets of indicators. And we're planning next month to actually get someone from quality assurance to talk about or the ideal web tool and all the details around it. But you can add a little bit of detail now if you want. And then the DATCOV tool, what are the exact elements? And is there sort of a tool that we could say, well, that is what is being collected? Because the fields of data collection and perhaps the indicators that you derive out of them would be very helpful to researchers to know, well, that is actually what is collected. Mr. Kumalo, do you want to respond to that? Can you tell us a little bit about what kind of data in DATCOV and in Ideal Web? Am I wrong about the Ideal Web basically being the ideal clinic manual?
Yes, Prof. Thanks. Let me start with the Ideal Web.
Yeah.
You are right. Yes, it's the Ideal Clinic Manual and Ideal Hospital Manual. Yes.
Right.
But on top of the Ideal clinics and Ideal Hospital, there is also other elements that are collected there.
Okay.
The PSIs, they're collected in the system, the patient safety incidents,
right.
The complaints that are received by the facilities are also monitored via the Ideal Web.
Right.
The severity assessment codes, the reporting and the case closure, all those ones, they come from the system and many other quality, but for now, just focus on those three.
Right.
And many other quality assurance indicators. Probably the colleague from QA will explain it even far better.
Yeah, I think that's worthwhile for us to get that person to go through it, because I think if we can look at this QA type of data and understand it, I think researchers might find great value in interacting with that, and for the department itself as well.
Yes.
Yeah.
Yes.
DATCOV data, again, do you have, I mean, is that, do you have a tool that we could look at that you could share with us as, you know, these are the different data fields collected, maybe the indicators as well? Do you have such a list?
Yes. Unfortunately, DATCOV is web-based. So my understanding is that you capture in the tablet or through the tablets, or you capture through the computer direct from maybe from a patient record, or but there's not really a register, standardized register where that information is captured from.
Would someone be able to share with us that app or that online tool?
What I can do, I can quickly share the elements just very quickly. Unfortunately, it has a patient data.
Okay.
Yeah, if you can. I can just for the purpose of, I will hide all the information for the purpose of this presentation.
Yes. And you can always send that to us as screenshots as well. I'm just wondering about time. but you can share it with us at screenshots. If it's a lot of information, we can do it on another occasion as well. But maybe just go for it now and let's see what you can share. If it is a lot, we'll do it on another occasion. I think just to answer the question that George raised about non-communicable diseases, there is actually very little information being collected in the DHIS. So if you look at the DHIS tick sheet, which we can make a copy available on this web page as well, there is really very nominal data collected. You know, there are some fields like age of diabetes, control or not control, etc. Some very basic information. It doesn't actually put information like the actual blood pressure values, etc. And then, so because it's just not even identifiable data, it's just collected as a whole, and so it doesn't really mean too much. But I think that we can share that and do that on another occasion, go through the actual DHIS information and challenges around the validity of the data and data collection. We could do that on another occasion. Perhaps with Mr. Kumalo, he can refer us to some other people. So let's just say we call that, we keep that for another time as well. Mr. Kumalo, you want to go through that DATCOV data briefly, and we can then close at that point.
Yes. Actually, I forgot my password.
Okay.
If
We
you
have
just give
another
me
question.
about just 2
2
seconds, yes.
Go ahead. Mr. Moyo asked the question, I think Satlule Moyo asked, can researchers access data that has not been captured in any website? So in other words, you want access to data in the hard copy forms and files. Yes, I mean, it is possible to do record reviews. The problem is that if it is DHIS data, so you can always look at files, etc., doing it, and that is not the DHIS process. I think that I'm not sure that the DHIS will be very happy for you to look at the raw forms of the DHIS in a facility unless you are, it could be available. I think Mr. Kumalo can answer that question. But DHIS data is only formally agreed to by the DHIS in the district when they sign off that this is the correct information. So once that it is actually in the DHI system, and then once it's there, it belongs to the HIM, and the district research committee, in fact, doesn't have any control over that, I think, process. So just to clarify us. And I think, Mr. Kumalo, we also, as the district research committee, have not been very particular thinking about people who come to us requesting information from HIM. We should actually be directing them to you. We've actually been doing that, and I think the problems come up later when they're asking for information and we have to talk to you about that fact. And so we need to clean up that from our side as well. Mr. Kumalo, if you are already able to share, you can go for it. Do you want to answer the question about accessing like DHI's data in a hard copy at a clinic or sub-district level? Would they still have to go through you at HIM? That's apart from patient records.
No, I think you answered it very well, because from our side, we only give what is from the DHIS. So if they want it from the records, then they would need to go via the DHS chief director,
right,
who will give access to review records in the facility.
Yeah.
If it's in hospitals, they will need to go via hospital services. DDG will give access to review records in the hospitals. So for us, we're just managing the systems, not the records.
Okay, so just for clarity, those of you who want to do on hard copy records of the DHIS or any patient record, that has to come to the Joburg DRC as an example. Okay. Mr. Kumalo, you able to share or do you think it's challenged?
No. I forgot my password.
All right. Let's not worry about it. We'll do it on another occasion. We've already gone over time. We thought we'd only do an hour of this, but thank you. I think this has been very, very helpful. We, in fact, have recorded it. So the recording will be available on the web page for the advert, and I'll just quickly post that on the link here, so you can go back to that link in an hour or so, and you'll see the recording there. And hopefully, once I get the documents from Mr. Khumalo and Mr. Madao, we can make that available, their presentations as well. So just to clarify, I think in terms of accessing HIS data, you need to reach out to the HIM's office, and Mr. Khumalo will provide me the email. I hope he can provide us the data access form, the NDA agreement, and exactly who they should email for that. And his presentation will also be available with the recording on the web page I've just put out there. I think that should be fine. Mr. Mudar and Mr. Khumalo, will you please send me your presentations and the relevant forms, and we can try and make sure that people can reach out to you and deal with accessing this data easily. So if you do that, I think people really appreciate that. Well, thank you all very much. Thank you, Mr. Badar. Thank you, Mr. Khumalo. And on behalf of us, thank your colleagues for providing you, telling you to come and share with us. You've done an excellent job, and we really appreciate it. So to everyone who's joined us today, well, thank you very much for joining us. Shabi Musaf, Chair of the Joburg District Research Committee. This is a regular webinar we run, and we hope to do one next month, looking at hopefully the QA data that we could look at as researchers, and see if we can make it easily accessible for you to do some work around it as well. So thank you very much. Take care and keep in touch. Watch out for the next webinar. Bye-bye, everyone.